Very good evening to everyone watching us from different parts of the world as well as from different parts of the country as well. We welcome everyone to a webinar on brain-based visual exercises for digital eye strain for different professionals, organized by International Association of Neuroscience in association with Bioleagues and Accommodation. So, without much delay, we'd like to introduce our speaker for the evening, Dr. Sharmila Devi, who is a certified ocular neuro rehabilitation therapist, a certified NeuroManual therapist, director of Indian Ergonomic Healthcare, and also a physiotherapist at Pondicherry Sports Association. Ma'am, we welcome you to the webinar.
Thank you, sir.
And we'd also like to introduce our moderator for the evening, Dr. Shrisruthi. Who is a pediatric physiotherapist at Chennai, India. Ma'am, we welcome you to the webinar.
Thank you so
And
much.
we'll also be shortly joined by our chairperson for the evening, Dr. P. Nagaraj, who is the lead consultant, neuroscience, sports medicine rehabilitation and lifestyle at Chennai, India, and also the editor-in-chief of Neurocosm International Journal. So we'll be joined by him shortly. So without much delay, we would like to hand it over to Dr. Sharmila Devi, ma'am. Ma'am, it's over to you for the presentation.
Okay, I can continue now, sir.
Yeah, you can, ma'am.
Okay, very good evening to everyone. I'm very thankful to Dr. Nagaraj and International Neuroscience Association and Bioleague and Techno Ariate group. I'm very happy to see you all here. Today, I will be speaking on about brain-based visual exercise for digital eye strain. Actually, so can you move on to the slides, sir?
Yeah, I'll just put it on.
We are living, I can say, and we all know that we are living with a technology like a computer, iPad, or mobile phone. Previously, we used the technology like computer only for an official purpose, but nowadays we are using it for even for a leisure, starting from waking up alarm and then moving on to daily messages, early morning messages, then emails, then on up to the any WhatsApp messages and mail, and then for various video. That nowadays even TV serials are also uploaded in videos in mobile. So we are watching over that, even for a film, for anything, even if a child or eating only on seeing playing a video game. This is a current situation, and we are facing various health issues. That is, previously even I spoke more about the postural health issues like neck pain, shoulder pain, back pain, and more beyond that there are more problems out there because of this technology, like digestive problem, like cardiovascular diseases, diabetes, knee pain, and towards from head towards a foot there is a problem. Why not the vision and the eye? Yes, of course, vision and eye are drastically and more affected by means of this digital technology like mobile phone and from the computer. So today we are going to see about a deep in depth how it is get affected, how vision, how eyes are getting affected by this digital screen, and also how we can manage by means of a visual exercise and by means of a few ergonomic tips related to it. Okay, let me move on to the topic. Okay, digital eye strain is otherwise said to be as a computer vision syndrome. Because why we are saying it as a why we are saying it as a digital eye strain? Actually, this digital eye or computer vision syndrome is a broad category of syndrome like asthenophia. Asthenophia is a muscle weakness or muscle strain, ocular muscle strain. It also leads to a various symptoms like blood eyes, irritating eyes, itching, and headache, migraine headache, and vestibular issues like this. This is asthenophia symptoms. And second is the ocular syndrome. Ocular symptoms like dry eyes, watery eyes, itching. These are the common problems even we are facing. Even if after half an hour or 1 hour on viewing this display, even you may get tired. Even I may get tired. Okay, so these are all the itching, irritation, dry eye, watery eyes. See, nowadays children will be constantly using the mobile phone for video games. The eyes will be tearing out from the eyes. Even still, they will be gaming over the mobile phone. Okay, that is the situation now we are facing, and this is the ocular syndrome. And third is the extraocular syndrome. Extraocular syndromes like neck pain. I am looking at this laptop with this forehead posture. Ultimately, it causes the neck pain. Because of this neck pain, shoulder pain, and back pain are occurring. So these are the extraocular syndrome symptoms. And fourth is a visual symptom. Visual symptom like double vision or blurred vision. Images that are letters, we can't see the letters clearly, or we cannot see the images clearly, or we can see a double images, that is a double vision or blurred vision. These are all the common symptoms. These complex symptoms or together comes under this computer vision syndrome. So computer vision syndromes composed of a broad symptoms of asthenophia. Asthenophia is otherwise called digital eye strain. And second is the ocular symptoms, and third is the extraocular symptoms, and fourth is the visual symptom. These four symptoms complexly together comes under the computer vision syndrome or a digital eye strain. Uh, Actually, this was said by the American Optometric Association. Okay, before getting into the topic of why we are doing exercising for this computer vision syndrome, you have to be aware or orient towards the normal structure of the eye and some of the pathomechanics and pathophysiology of the eyes. Okay, so this is the cornea. Outer layer is the cornea. Then this is the sclera. Outer layer is the cornea and the sclera. Then the middle layer is a choroid. This is the choroid. Okay, choroid continues, this red layer continues and form a ciliary body here, and then it ends up in the iris. Okay, between this iris there is a space called pupil. Okay, and here anterior to the pupil is aqueous humor, and it is covered by the conjunctiva. Okay, and this here over the ciliary body there is a ciliary muscles are there. Okay, two types of muscles are there. That is a longitudinal muscle. Here is a longitudinal muscle, and here it is a circular muscle. Same like this, iris also. This is the iris. Iris also having a constrictor pupillae, that is the circular muscle here. Okay, and here is a dilator muscle behind the circular muscle. Okay, this on contraction of this iris muscle and ciliary muscle reduces the space between the iris. Okay, that is reducing the space of the pupil. That is, it limits the light rays from entering the lens, entering the eyes. Here is the aqueous humor, and here is a pupil. So we have saw a two intrinsic muscle. Okay, that is a three intrinsic muscle. That is a constrictor pupillae, dilator pupillae, and the ciliary muscles. Here is a ciliary muscle, constrictor pupillae, and the dilator pupillae. These are all the intrinsic muscle, and here two lines are running. This is a lens, and this lens is attached to towards the ciliary body by means of a suspensory ligament. This suspensory ligament and this ciliary muscle altogether plays a vital role in changing the shape of the lens. This actually by the contraction of this ciliary muscle and this iris muscles reduces, it acts as a diaphragm. True to say, this muscle act as a diaphragm, allowing the light rays to enter in. Okay, then getting into it, beyond the thing, inner layer is a retina. Retina is a posterior layer, and here this is a vitreous humor or aqueous humor. Okay, so leaving that, this is a optic nerve. I am not getting you deep into the anatomy or over the physiology. The needed points I am explaining you. Okay, this is about the structure, and this is about the thing which I said, intrinsic muscle or constrictor pupillae. Here this is surrounded by circular muscle, and here is a longitudinal muscle. See, here is how circular muscle is contracting. because of bright light, and in dim light how this radial muscle is contracting. And this is a extrinsic muscle. Actually, we are familiar with this extrinsic muscle, like superior rectus. This is a superior rectus, inferior rectus. Superior rectus elevates the eye upward, inferior rectus downward, medial rectus medially, lateral rectus laterally, and there is a superior oblique and inferior oblique is there. It makes a role in extortion and intorsion, moving in and up, down and up, and then extorsion. Okay, these are all the extrinsic muscle, and we know it is supplied by L6, SO4, and third cranial nerve. This is the whole thing regarding a muscle. Apart from that, there is a connection of eyeball with the facial muscle, like orbicularis, oris, and levator palpebrae superioris, like that. There is a next connection is going there. Okay, so I'm stopping here. Okay, so why I said about this thing is, what happened, how this refractory power or how this eye strain happening is, see, initially when we are in the distance focus, if we are watching the object from the distance, we can see with a flattened lens. This lens will be flattened without any strain over this intrinsic muscle and extrinsic muscle. Intrinsic muscle will be relaxed straight, so we can see the distance object clearly. The light rays will be parallelly coming towards the lens. Okay, whereas, so if we are doing the near focused reading, texting, or anything, what happened is, this initially this iris muscle and ciliary muscle contract by thereby reducing the space of the pupil. Okay, this is the first stage. Okay, then what happened is, next is the superior oblique muscle. Superior oblique muscle, what happened is, it will be next to the contraction and tension created by the ciliary muscle. This tension is transferred to the superior oblique and inferior oblique muscles. Okay, so the tension or contraction sets in by the near focus. Okay, so it will, if we are doing for 1 hour work over the computer, it will relax. After 1 hour, after rest, if we didn't again refix over the computer, means that symptom or anything, that strain or contraction, everything will go for relaxation. Okay, what happened if we prolong our work? What happened is, next to this muscle, that is superior oblique and inferior oblique, this sclera, this is the sclera, this is the outermost layer of the eyeball, which maintain the shape of the eye. This is also important, this eyeball, this sclera also maintain the shape of the eyeball. What happened is, this sclera goes for an elongation, thereby increasing the length of the eyeball, along with that rectus muscle goes for relaxation. Only if the rectus muscle is relaxed state, this sclera goes for elongation. So this is a normal mechanism for accommodation or convergence. That is, for few minutes or few hours it can withstand. If the ciliary muscle cannot withstand the tension, or it goes for fatigue, means this ciliary muscle have to compensate it. This sclera has to compensate it. If the sclera doesn't compensate, the rectus muscle goes for eccentric lengthening or over contraction of the oblique muscle. This is a mechanism of getting the fatigue or strain, digital eye strain. See, this is the accommodation. Initially, the lens is flattened. See how this is contracted. This ciliary muscle is in relaxed state. So because of the distant vision, the light rays run parallelly towards the lens, and it requires minimal strain to refract the rays towards the retina. Okay, light rays have to fall over this retina. We to send the impulse towards the brain to see the image. This is a normal thing, normal process. What happened is because of closer vision, the light rays, it goes for divergent. Here is a parallel light rays over there, but because of closer vision, the light rays will get diverged, and it gets more strain by the ciliary muscles and make the refraction properly, and it get focused over the retina. If this is happened for a few hours or to few days, this will be happening good way. But if it goes for a prolonged or long term thing, what happens is this light rays won't touch the retina, it will fall before the retina. Okay, that is we cannot see the distant object. Myopia or asthenophia. Next stage of this muscle strain of asthenophia is the myopia. This is what we are getting. Okay, so this is the convergence. Okay, both we are seeing the object as a single image. Convergent, if we are see that is closer, reading a closer text and all, we are converging our eyeball, and for viewing the distant vision, we are utilizing the distant vision. Okay, and then next is this is what I said. Here is a parallel beam of light rays coming, entering the eyes, and it get refracted over the retina. Here oblique muscle, everything is relaxed. See here, oblique muscle, everything is relaxed, and the lens is flattened. Okay, this is a normal distant vision. And see here is the oblique muscle. What happened to oblique muscle in case of near vision is this oblique muscle goes for spasm or contraction along with the contraction of the ciliary muscle over here. If it continues for a long time, the sclera will take over this action to relieve the tension of the ciliary muscle. That sclera what make is it elongates these eyeball. See, it's elongating the eyeball, so this length is more comparing to the distant vision in near focusing. Okay, what happened is here oblique muscle, superior oblique and inferior oblique muscle are contracting in near vision, and rectus muscle is relaxing. Okay, and next is if what happened if this thing if this near vision is set for prolonged time, okay, more number of hours without any break, means what happened is it will make the refracted rays to fall before the retina, so we cannot see the image, distant image clearly. Okay, this is what I said. Here sclera, everything will be in tension, and superior oblique and inferior oblique will be in constant tension, and it even goes for strain. Okay, same like how if we repeatedly work over the keyboard, we are getting carpal tunnel syndrome. This is a work related problem or overuse injury. Same like that, it is also this eye strain is also a overuse injury because of constant focusing and refocusing. Okay, constant focusing and refocusing of the eyeball, or constant contracting. See, if I am keeping this bicep for in a contracted state for long time, what happened is long time and for a many long days. Okay, for any sort, it goes for contracture or spasm, and then leads for contracture. The same thing is happening. This superior oblique muscle in myopia or asthenophia or in digital eye strain, this superior oblique and inferior oblique goes for spasm along with this ciliary muscle. This is a concept. Next, the sclera makes the eyeball elongate. This is the pathomechanics. Okay, and then this is the myopic eyes. Here you can see same thing, and usually what we do is we can correct it by means of a lens or by means of a anything. Okay, like contact lens or by means of a spectacle, we used to do like that. But as a physiotherapist, what I am trying to say is, as it is this change in the refractive power or this eye strain, or due to change in the shape of the lens, the change in shape of the lens is primarily because due to the eye strain or eye muscle strain. We have to relax that eye muscle. Okay, so we have to exercise that. Also, as visual impulse from the object is over the eye and it goes to the brain, everything is processed in the brain. Okay, there is each separate area for that is impulsive goes from the eyeball, it goes to the thalamus. Okay, that decussation, partial decussation happening, so we are getting the bipolar vision. Okay, normal vision, and then goes to the from the thalamus, that is lateral geniculate body, and it leads, and also it will end up in the superior colliculus of the midbrain. These are the two from the retina. It goes to the lateral geniculate body and the superior colliculus, from the superior colliculus to the many areas. Okay, like primary visual areas, or it is going parietal, frontal eye field. Frontal eye field initiate the movement. Okay, so everything's initiation of movement, color perception, everything is going on in the brain. So if we treat only the vision, it won't get full globe of management. So we have to correct the brain too. Like in order, if we see even nowadays, even for postural correction, I am insisting people to concentrate on brain based correction for a postural pain like neck pain or shoulder pain, because if the problem root cause is not sorted out here distally, the sort of accommodation of plasticity set in the brain also because of this problem over distally. So we have to correct both, or else recurrent problem or recurrent pain will be coming. So we have to deal brain based management. Okay, both for a distal problems and for the visual problems. Okay, so till now we saw about a pathomechanics or mechanics, and now we are entering into the pathophysiology of a computer vision syndrome. See, there is a difference between how we are viewing the text in a blackboard and how we are viewing the text over the computer screen. If we see the text over or image over the that is blackboard, what we can see the full length of the letter. See, if A is wrote over the board, means blackboard, means we both the center board and over the edge, it acts like a solid structure. We can see without any strain. What happened on a computer screen is it will be in the pixel form. That is, the central part will be darker and the outer part will be blurred up. So we have to focus. We can focus it, and we are focusing it, but we cannot sustain that focus. See, if teacher is teaching with a blackboard, means we all the way we can without any fatigue of the skeletal muscle, we can see by blinking the eyeballs for any long time. Okay, but see, for if we see over read the text over the mobile phone or over the computer screen, means this is not a sort of thing. We are focusing and we are refocusing. That is, we are looking at the image initially, then we look beyond the computer screen. See, initially we will be looking at this computer screen. Later, as we cannot withstand that focus, we are looking beyond this computer screen. That is called the resting point of accommodation. This is what happening usually. So this focusing and refocusing leads to a strain over the eyeball. That is contraction, relaxation, contraction, relaxation, contraction, holding. What happened? It causes the spasm or it causes the strain. Okay, the same thing is happening. Okay, previously I said about the symptoms of computer vision syndrome or a digital eye strain. That is a complex of syndrome from asthenophia, ocular surface related thing like watery eyes. See, here I have to point out you dry eye. Actually, this dry eye is a main cause for this computer vision syndrome or even for this asthenophia. Usually, the eye layer is having a film of watery film of tears over the entire surface of the eyeball. Okay, so this tear layer is composed of three layers. Okay, tear film is composed of three layers. Outer layer is a oil layer, middle layer is the watery layer, and inner layer is the mucus layer. Okay, so this oil layer prevents from drying the eyes. Okay, this oil layer is secreted by the meibomian glands. This meibomian gland is present over the eyelids, upper and lower eyelids. Okay, so here the oil layer of the tear is secreted, and next is the lacrimal gland, which is secreting the watery layer, which is in the upper eyelid. Here is the lacrimal gland. This watery layer, which is we are seeing usually, okay, which is dropping off from the eye when we are crying and all. Okay, so this will remove the dust. Okay, and then inner layer is the mucus layer. This mucus layer, it allows this watery layer to bind with the eye surface. So it moves the eyeball. When we moving the eyeball eyelids, we are moving it relaxedly or smoothly. Okay, this is happening so that this mucus layer, what happens, it makes stick this tear layer towards the eyeball. Okay, so all these layer have to be get function well. All this, for this mucus layer is secreted by conjunctiva, which I said, outer layer, outer covering of the eyeball, and inner surface of the eyelid. Okay, so these three things have to function well. If if this will function, there are many other causes, pathological causes are there, but one of the cause here in computer vision syndrome is we are constantly staring over the computer screen without blinking. Nowadays we are people, even children and we are youngsters, we are forgot to blink. Usually we will blink many times. Okay, and also we are constantly in over the AC, under the AC air conditioner room, and also it will make less humidity, and also that makes the eyeball dry. Okay, also if we are under the fan or something, direct air surface means the eyeball gets goes for dryness. Okay, this causes this ocular surface problem or symptoms. Okay, then blur division, because of those things, accommodation problem, convergent problems, and everything, vergence, that is convergence and divergence problem, or because of saccadic movement, that is if I am saying to look at this 10 number means my eyeball have to move this 10. If I am saying to move my eyeball towards the 9 means my eyeball have to move towards the 9, and 12 means I have to look at the 12. So saccade to the number or saccade to any auditory stimulus that we are saying. If I am saying you to see that, look at the light, my eyeball have to look at that look at that light, either by moving the eyeball upward or laterally or any direction smoothly. And smooth movement of the eye is called a pursuit movement. Okay, and what are all, these are all the movements we saw, and these are all the symptoms we saw, and this is a causes for computer vision syndrome, which I said poor. Here I have to give importance to the improper sitting posture. See, if you place the thumb of the finger over the neck, under the neck, here you see, you keep under the occiput, okay, and move the eyeball medially and laterally. You all can do now. You move the eyeball medially and laterally by keeping it. What we can feel is, you can feel the movement of the eyeball. There is a connection between the eyeball and the neck musculature by a neural thing. So what happened is, because of this eye strain, it may cause the neck pain, or this neck pain and improper posture may cause the pain over the, or may cause strain over the eyeball musculature. Okay, this is what I'm trying to say. So this improper posture, forwarded posture, can cause eye strain, not only by constant staring over the visual screen, but also by the neck posture and all. Okay, next is computer vision. On computer vision syndrome, I should not omit about saying a blue light. Blue light is a shorter wavelength. It gives the mobile phone a brightness. It gives the mobile phone a brightness and all. Okay, and clarity of the image, everything. So there will be a orange, red, and green light, visible light will be there, but they will reflect here. Before it getting into the eye, it will reflect here. What happens to this blue light is it will enter the eyeball and hit over this retina. Okay, this blue light, even though it is a short wavelength means depth of penetration will be more and have a high energy. It cause a damage to the retina, and also it will affect the circadian rhythm. That is melatonin will be produced over by the night time. What happened is because of this melatonin suppression, we this day sweet sleep cycle will get affected. Okay, so this is a main problem of blue light emission by the mobile phone or even the computer screen. Okay, so what are all the things that is affected by means of digital devices? Accommodation, which I said previously, virgins, pupil gets contracted, shortening. That is the space between the iris uh, is reduced. Okay, so this change will be affected, and blink characteristic. We are forgetting to blink. And eyelid physiology, that is about the production of meibomian and everything. Every physiology gets affected by means of this digital device. So we are for all these problems. Here we saw about the entire thing like muscle pathomechanics, how it get affected, then the pathophysiology we saw, causes, everything we saw, and now we are getting into the interesting point, that is the management, that is a brain based exercises. First one is a fixation. See, if we want to see an object, our eyes have to fixate on an object for some time. Okay, if it get affected, we cannot proceed over anything. So fixation we have to manage. So for eye fixation, we have to see I am holding my finger like this in front of my eye, okay, at the eye level, and I am holding it for 10 seconds, and I am fixating my over the finger. Okay, if I can't fixate means there is a fixation problem, and we have to train over that. Okay, we have to increase from 10 seconds, then 20 seconds, then 30 seconds, like with blinking and all. Okay, so this is a fixation exercise. Then next is a visual acuity. Usually it will be assessed by a Snellen chart. And in order to train that visual acuity, actually this visual acuity will tell us the integrity of the cranial nerve too. Optic nerve. This cranial nerve to integrity was set by means of we can assess by means of a visual acuity. Okay, how we can train that visual acuity is there are small images. See, if you start from the very small letter like ABCD over the Snellen chart or even anything, even over the iPad app or there. Okay, so we can start from viewing that small letter for 5 seconds, 5 to 10 seconds. Okay, for a week, and then we can increase the time duration, and we can increase the size of the number like that. We have to start from the small letter on focusing that for 10 seconds. Okay, like that we have to extend the period of fixation. Okay, reading. Okay, this is about the visual acuity. And then the eye dominance. For eye dominance, see what happened is while we are we have to train eye dominances. We usually, if I am a right-handed dominant person, my right shoulder will be mostly affected, and overuse strain will be happening. Same like that. If I have a right side dominant eye, I am having a right side dominant eye. I have more. I can have it more chance to get eye strain over this right eye. So we have to assess that dominance of eyes, and we have to manage that. Okay, we have to it is not a right thing to keep one eye dominant and another eye is less dominant. We have to train them both. Okay, so I teach you how to assess the eye dominant. First, you have to place your hand like this triangle. Okay, you have to fixate an image at a distance. whichever, see, all these exercises which I am saying, even for assessment, you can assess with the spectacles or with the lens, because we are dealing with the functional aspect of the ocular assessment and brain based assessment over the functional thing. If we are doing the activities and everything with wearing the lens, means we have to assess with the lens. Okay, so we have, for eye dominance, you have to keep your hand like this, triangle. Okay, and in this gap, triangular gap, you have to focus one image at a distance point. Okay, so you have to keep both the eye open initially, and you have to see in between the triangle. Later on, what you have to do is you have to close one eye. Have to close one eye and have to focus on the same object. If that object is not within the triangle, that is not a dominant eye. If my right eye, I am focusing the laptop or exercise. This exercise spelling, I am focusing. Yes, I am focusing. Okay, I am opening my right eye, closing the left eye. I can see the yes letter within the triangle, but laterally, but not over central part. So, and then I am seeing over the left eye, closing the right eye, and this S is over the center of the triangle. So, have less dominant over the right eye. Okay, so like this, you have to assess the dominance of eye, and you have to train that. How you have to train the eye dominant is, you can wear any eye patching thing, like, or you strap is head strap is there. If you can cover with the help of head strap, you have to wound around that head strap, or bow we are wearing to arrange the hair, no, that you can, the cloth bow, you have to wear it like this. Okay, and by closing the left eye. Okay, that is a non dominant eye. We have first, initially we have to close the dominant eye, and with the non dominant eye we have to play any ball, throwing a ball. Okay, or we have to catch the ball with the non-dominant eye, like that. Actually, this will activate the accuracy and also the dominant. It will activate the cerebellum also for accuracy and all. Okay, so we are along with the dominant training, we are activating the cerebellum also. Actually, this sort of thing is usually training is usually given to the athletes also. Okay, and then now we saw about the fixation, then visual acuity, then the dominance of eyes, then the convergence. Actually, there is a convergence problem is there. That is, by assessing the convergence, brain-based assessment, we can assess the integrity of the cranial nerve 3 and also midbrain. From midbrain, the tract that is superior colliculus is there. Superior colliculus, superior structure of the superior colliculus is receive the impulse, sensory impulse from the retina, and also the deeper layer of the superior colliculus will send the return impulse to the eye to initiate a movement and all, to make the eye movement, superior colliculus. So that superior colliculus is present in the midbrain, and also medial longitudinal fasciculus, that is the vestibular nerve, that there does the nerve from the neck muscle and the visual muscle, everything is connected over the brainstem and it travel downwards. Okay, so any compromise in any of the three nerve will cause the compromisation in the activity of another muscle. Okay, so this is about the conversion, and how to assess the conversion is, you have, from the distance, you have to focus the tip of the pencil. From the distance, I am getting my pencil closer. Okay, if I am getting two pencil, if I can see two pencil, I have to stop it there and have to hold for 10 seconds. If while holding, if I am tilting my head like this, or if I am get saccadic movement, there is a problem or weakness over the midbrain or over the cranial nerve 3. That is, cranial nerve 3 is not sending the impulse properly from the retina towards the brain. Okay, or you can say this convergence problem is there. Okay, so we have to train this by means of the same pencil push up. You have to keep this pencil in a distance arm's distance, and have to get it closer, and have to hold it before you are getting double image. You have to stop there and have to focus and hold for 10 seconds, and then again you have to relax. This is for the convergence, and the same along with that convergence, there is accommodation problem are also there in digital eye strain. So in accommodation, you have to move from the distant vision, and how to distant vision you have to hold it for 5 seconds, and then in closer vision have to hold it for 5 seconds. Alternatively, you have to do it for 3 times. If you have a problem with this accommodation, there is a problem with the midbrain, and also you have to see this thing, train this accommodation by means of this pencil push-up. And also this is about the fourth. And saccard is, which I said, you have to saccard to the number with the instruction of the external person. You have to saccard to the number, any number, auditory stimulus, wherever, whatever we are saying. The external therapist, we have to follow that without the eye movement, that is support to the stimulus. Also, I said, in case of eye strain, because of asthenophia, you are getting the migraine headache and all, and in migraine you are getting the vestibular problem, vestibular ocular reflex are also getting affected. So what you have to do is, you have to hold a pen or pen tip like this, and without you have to see the pen tip by moving the eye quickly, with quick movement. Okay, this is the testing and treatment for the vestibular horizontal canal of the vestibular vestibular ocular reflex. We are managing it. Vestibular ocular, if we correct the vestibular ocular reflex, forwarded posture will get corrected. As I said, in everything is travel over the midbrain, so everything will get corrected. Okay. Also the asthenophia and also the neck strain, that is, it prevents the flexor dominant posture. Okay, midbrain, it will prevent the flexor dominant posture. Cerebellum, it will make the extensor synergic, extensor activity. So along with the cerebellar activity and the midbrain, we are getting the erect posture with the clear muscle. Okay, and these are all an ergonomic recommendation. You have to see the computer screen with the arm length distance, and for good mobile phone reading, you have to keep the mobile at 41 to 46 centimeter, and for TV watching, we have to measure the width of the TV screen for into the, you have to multiply it with 1.5. For example, if you are having 32-inch TV, you have to,
Hello.
yeah, yes.
I'm sorry to interrupt. It's
It's
okay.
finished. I'm finished.
Make it fast.
Okay.
Yeah, thank you.
And this is about the ergonomic recommendation, and these are the few literatures that's sent. Thank you. I have taken much more time.
No problem. Thank you so much.
Yes, thank you.
Thank you, ma'am. It was a very wonderful session, and we could learn many points regarding the visual exercises, and it is one of the most untouched topic. So I request Ashish. Hello.
Ma'am, we don't have any questions, so I think you can go for a short moderation, a brief summary about something, about the topic, then we can wind it up. Ma'am, over to you.
Yes, ma'am. Ma'am, I have few questions regarding the session. Since you are a pediatric therapist, so how would you recommend child for visual exercises below 7 years?
Yeah, actually, that is whatever exercises which I said is everything. It's an app also. You can use any app model also, or the same thing. We have even for a pediatric. For a pediatric age group, if we take a school-going student, this sort of instruction they can understood. Okay, instead of pen tip, we can ask them to throw a ball like that. Okay, everything according to the understanding of an age group of a thing, people, children. Yeah, even for pediatric children, in case opokinetic thing and all, we can use a throw. That is, we have to throw a ball, and you have to keep move the smooth movement, looking of that object, smooth pursuit, without moving the head. You have to look at that ball, where that ball is going and touching the ball. Okay, like that we can change the instruction. Okay,
Yeah. Ma'am, how many repetitions do you
that is four times all these things, four times a day. Even in case of office workers, they can practice this sort of, this was simple thing. Okay, that is, I'm asking to say, tip of to visualize at the tip of the pen and all. So these can practice even in the office or in school, wherever. Okay, even in the leisure lunch break, everywhere they can practice, and they can practice for four times a day. Okay,
thank you.
without straining the eye, because if they make a strain over tried, means it will goes to skew of the eyeball. Okay.
Uh, Thank you, ma'am. It was a great presentation again. And over to you, Nagaraj, sir.
Yeah.
Hi,
Thank you.
sir.
Hi, good evening, Sakita.
Good evening, sir.
Good evening. Good evening, Ashley. So I'm just happy to welcome you all. So it was a very good, excellent webinar presentation. As you keep walking, it's not the first time seeing your lecture. I'm so happy with your presentation. It was quite informative and very insightful. A lot of information. The problem is the period of time. The time is very short. It's a very elaborative topic. So, but you covered up maximum. So you made all the efforts to make it reach to the people. So I thank on behalf of IAM for an excellent webinar presentation. And I also thank Dr. Shruthi for the moderation. And I thank, as usual, like I was discussing Mr. Asas every time I used to disturb him and blog. So thank you, Asas. It was an excellent presentation. I thank all the audiences, all the participants on behalf of IAM. So it was very, for information, it is a very unique presentation. We have not touched this topic. No, most of the people never touched this topic. So I thank especially our speaker, Dr. Sharmila Devi. She is very she is a specialist in oculoplasty. She is basically a pediatric physiotherapist, but more interest on focusing on oculoplasty. She is doing a research study on this aspect. I wish all the best, Dr. Sharmila Devi, for your effort.
Thank you, Dr. Nagaraj.
And so that it reaches all the audiences, all the professionals. And I just like to, we want to have some more the same something continuation of this topic, because I see a lot of people feedback. Yeah, but the thing is that it's very elaborated, but we have to give you more time. But the problem is that more than 45 minutes is very difficult for us. So I think you did a wonderful job. Thank you again, Dr. Sabat. Thank you.
Thank you.
Thank you.
Thank you, Asis. Thank you, Shruti. Thank you,
Thank you.
the whole organizing team. Thank you. Shall I leave this?
We'll just wind it up. So, like before, as we are every time do before we end this, the participants who have registered for this webinar will be receiving their certificate soon through their mail IDs, and they'll also receive a link for their feedbacks as well, so they can fill up their feedbacks for this webinar as well. So, till the next time, we would again like to thank our speaker, Dr. Sharmila Devi, our moderator, Dr. Shrisruthi ma'am, and our chairperson, Dr. Nagaraj sir, for this beautiful webinar. And we assure everyone, as we always do, that we'll be coming up with more interesting webinars in the future as well. As we all know that every week we sort of conduct a webinar of any association, be it oncology, neuroscience, pharma, nursing, anything. So we'll be coming up with more interesting webinars in the future, and we'll keep everyone updated about all the webinars that we conduct in the future as well. So till the next time, we again like to thank our speaker, moderator, and chairperson for the informative and beautiful webinar. And till the next time, we sign off from now. Thank you, everyone.
Thank you, Asis. Bye, everyone.
Bye bye.
Bye bye.